Amandla. 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 Louder, come on. Amandla. Good evening and hello everybody. Hola and namaste. We are delighted to welcome you for an official public launch for Community Voices in Health Governance. This project will examine how community participation can strengthen health service delivery in countries with plural health systems, where care is delivered under one system by both public and private providers. It is a collaboration between researchers, health services, and community organizations in Brazil, India, and South Africa. It is funded by the National Institute for Health Research in the United Kingdom, but led by 7 country researchers. In this next 90 minutes, we will begin with an introduction with Professor Leslie and Christine from the Menenberg Health Committee to co-introduce the project and the objectives. And then we'll ask each country to come and present their vignette. And then we'll ask the speakers. I think there's some disturbance in the mic. I'll just put it away. Okay. And after the vignettes are being presented, we'll have the speakers to ask questions and reflect on the vignettes. And then we'll bring it open to all of you to ask new questions or having open discussions.
So can we ask everyone on the online, just mute your microphones.
I think we are. Yeah. Okay. So please welcome Professor Leslie to begin with the presentation.
Okay. Thank you, everybody. Thank you, everybody. For those of you online, there's only 2, I think. We are going to share screen, and we are sharing screen. As Smriti explained, this is a project which is looking at community participation. It's our public launch, and we're fantastically pleased. We have a lot of community members here, a lot of people from the university, a lot of people from civil society, and some colleagues going to be commenting in response to the presentation. So what this is about, it's about community voice in health governance. It's about translating public participation into practice in a world of, and I'll use the word pluralistic health system. And by plural health systems, we mean systems where you have provision by public services, but also provision by private practitioners, private hospitals in one system. That's why we call it plural. And it's happening around the world more and more. And in South Africa, we're going to see it happen with the National Health Insurance. But we're very pleased that we have a collaboration with researchers from Brazil, where there's a lot of public-private involvement in the national health service there, and also in India, where there's not a lot of collaboration in a structured way, but it's a different context. We want to learn from the different context. It's a project funded by what's called the NIHR, the National Institute of Health Research in the UK. And it's about looking at how participation and pluralization can coexist, and in fact can try and strengthen each other. So on the one hand, participation is about trying to improve equity and access and quality and efficiency in healthcare. And pluralization is often introduced with many similar objectives, trying to improve access, quality, and efficiency. And participation is a strategy that is really about a political process. It's about democracy. It's about democratizing policy processes. Whereas pluralization is often a technical response from managers to try and improve the technical capacity of a health system. How can we deliver more services to more people in a more efficient way? Participation has its roots in political theory. We would like to believe that we live in a country where you can vote, you can express yourself, you can have your say. And in Alma Ata, the Declaration of Primary Healthcare, participation is very strong. In fact, it's not only actually a duty of people to participate. Whereas pluralization, when we talk about introducing the private sector, it often has its roots in market ideologies, that the market will help you be more efficient. And sometimes it's introduced by relying on what's possible in practice. We have examples of participation in South Africa and other countries. Hospital boards are set up to try and get more participation in hospital services, health committees, clinics and community health centers, district councils are all set up to try and improve participation. In examples in South Africa of pluralization, you might not know that recently there was an experiment, a pilot in the West Coast, where private providers were contracted to provide obstetric care and delivery to pregnant women. And there was an effort to do that and improve access to care for pregnant women with obstetric services. So if you think about a private health sector, if you want accountable health care, there are different factors at play here. Firstly, the private sector might set up their own quality assurance system, private quality assurance system. They might also try and follow regulating standards to improve the quality of care for individual patients. They will also have contractual relationships, so those might also influence the quality of care. And then most private care in South Africa is delivered through a medical scheme, through health insurance. And if you're a member of a health insurance medical scheme, you can try to influence your medical scheme better by how you engage with your medical scheme. On the other hand, in the public sector, we know that the public sector has many quality assurance systems. There's the Ideal Clinic, there's the Office of Health Standards Compliance, and also there are statutory systems for participation. So many of you are health committee members, and the law says there must be participation by communities, there must be health committees, there must be hospital boards. And on top of that, there are programs to foster community participation. I'm told I can't move.
Maybe you can pin it up. Yeah.
Okay, is that better?
Yes.
And of course, we live in a country with lots of human rights. We have a constitution which guarantees us many rights, and human rights place obligations on governments, on states, to do things. So you, as a user or member of the community, have entitlements to safe environment or to access to healthcare, and those things also influence how patient care is accountable. So when you put these two things together, you have two different systems, and they have to coexist and work together. And it's not entirely clear how that would happen, if you think about it. So in the public sector, we have the Office of Health Standards Compliance, the Ideal Clinic. Private sector, they each have their own system for quality assurance. Do they work together? Probably not too sure. Human rights put obligations on the state, on the government, but they don't necessarily translate into obligations on the provider who's contracted to do something. So maybe there's a question there, how do human rights impact individuals or private entities? That's also a question that's asked. The law says there must be health committees, but it doesn't say there must be health committees in a private clinic. And how do we manage that when there are contractual relationships, when the private provider is now going to provide services to an NHI? And of course, medical schemes have members, but those of you who are members of a medical scheme, you've never been to a meeting of your medical scheme board or AGM, I'm sure. You wouldn't even know how to do it, and you wouldn't know who's on the board or who's the director. because it's not geared towards promoting participation. So the statutory systems by law that say that there must be a clinic committee and a hospital board, how do they interface with private insurance? We don't know. Of course, human rights place obligations on the state, but it also says the state must regulate the private sector. So, well, if you're going to deliver care for the population, you must do it in this way. Perhaps you must say that you must promote public participation, community participation. And of course, that is part of government's obligation. So you can see it's quite complex when you bring the public and private together, but that is what's going to happen in South Africa with the NHI. So this project is about thinking through this question as a design challenge. So we have new ways of combining public and private provision, and they call attention to the role of institutionalized channels for community participation. So how do health committees function? How do hospital boards function? How do district councils function? And how will they contribute to health system effectiveness? And if the state, to whatever extent it can or does to comply with its human rights obligations to ensure meaningful social participation, how do they negotiate extending that to non-state providers, to the private sector, to faith-based organizations, to private NGOs who run community health worker programs? How do we build that into a system? That's a design challenge. And you know this, we have a tale of two health systems in South Africa. We have a public sector that's often over full, understaffed, shortage of services and resources. We have a private sector where often there isn't enough demand, so the providers encourage demand, make use of the private sector because they will get paid for it, fee for service. And that's the problem of the bifurcated health system, a divided health system, that universal health coverage tries to solve by saying you have to bring them together. Everybody in, nobody is left behind, the famous phrase, and that is what the NHI is aiming to do. So this project's rationale is the following. We know that there is evidence that says community participation can positively impact on health systems, even though we know there are many challenges with community participation. And I quote here from work that Hannah did, and who knows, maybe the person who said this is in the audience, I don't know, but she interviewed a lot of health committee members. And one of the comments was, we as health committees want to express our opinion as to what is needed in our communities. Please listen. So it's possible for health committees to be the voice of communities to convey to the health system what is needed. Participation is also rooted in our human rights framework. If you look at the Constitution, if you look at international human rights law, it's a right to participate. There's also some evidence that if you include private provision in the health system, where there is universal health coverage, you can enable quick expansion and improved access to care in peripheral and poor areas of big cities. That has happened in Brazil, for instance. We've seen how the private sector sometimes has stepped in the public sector. South Africa has failed to provide oncology service to cancer patients. They've done it quickly. So it's possible that the private sector can solve a problem. But the concern is that it introduces a private logic into the public system. Private logic would mean for profit. Private sector operates for profit. So the starting point of this project, if you want to try and foster the working together, the alignment of the bureaucracies, that's the public sector services, the politicians, the health professionals, the managers, and the community around the goals of promoting population health and well-being, and finding adequate mechanisms to integrate participation and pluralization together will make a big contribution to strengthening community participation on the one side, but then you would have a clearer mandate in implementing an NHI or any such pluralized system, and the contracting process where the public sector contracts private providers, because communities' needs and views and perceptions would be more adequately incorporated into those contracts. So when the NHI comes and it says we're going to contract with private hospital X to deliver service Y, they'll do it on the basis of what the community wants. So our overall aim is to strengthen the participation and voice of communities and community structures in urban systems, pluralistic health systems, where this is public and private together, better alignment of the different health system actors, and by that we mean the provide care, the people who manage care, the people who use care, the people in the community who haven't yet used care, all those actors, around the common goals of accountable, responsive, and inclusive health systems. What are we going to do? We're going to do various things. We're going to look at the policy landscape. What are the policies out there? How are they framed? Can they work together? Are they the right policies? Are they implemented? We're going to use in-depth qualitative research, interviewing people, getting information. We're going to track selective indicators around certain diseases to use secondary data to see if this is working. We're going to then develop interventions collaboratively. So we're going to co-design interventions with communities and with the service providers to try and build capacity both in the community and the services, and then we're going to evaluate them. We're working in 3 countries. There are 6 case studies, 2 sites in each country, Cape Town and Aveja. In Brazil, it's Sao Paulo and Fortaleza, and in England, Mumbai, Bangalore. And each country has a different kind of stage of pluralization. Brazil is quite far. South Africa is, we're looking at it in front of us, and India watching from afar. So we're going to try and share our experiences and learn from each other. This is what we plan to do. Our objectives, we want to firstly delineate the policy, institutional, and community context that mediate effective community participation with urban health communities. And most of that is the work package that's going to be reviewing evidence. So what has been published in South Africa, the world, etc. The second objective is to co-produce interventions with both the communities and providers to facilitate participation and community voice. And there are 2 work packages there. We're going to be collecting and generating evidence ourselves, and we're going to build collaborative partnerships, co-develop, test, and implement a participatory approach to seeing how a pluralistic health system works. Third objective is to evaluate the context, mechanisms, and outcomes of the implementation, and then refine the intervention. That is a program of capacity building, piloting, and evaluating the model. And then lastly, of course, we want to learn from different country contexts, foster capacity strengthening of communities, health systems, stakeholders, and global health researchers. And that will be comparison and dissemination. And you can see it's going to run over 4 years. We are well into our first year, but we hope we will be able to catch up. So what do we hope to deliver? In the short term, we want to create new networks, both within countries, so we're working in Cape Town and Aveja, but also with communities and across countries. So you will meet some of the colleagues from Brazil and India, not everyone, and at some point in the future, we hope we could have exchange where people will be able to meet community members in India and Brazil, if not in person, but certainly in other ways. We want to enhance research capacity from community co-design, including the community health service actors and young researchers capacity. And in short term, we also want to produce policy and practice relevant dissemination. So through a website, newsletters, publication articles, briefs, manuals for communities, etc. In the medium term, we hope this will strengthen community voice in systems of accountability and contracting that are needed for their time. We hope that we will be able to promote enhanced receptiveness of providers and managers to this concept, meaning that providers and managers will work better with communities. And we want to improve relationships of trust between actors. If you talk to some people about the private sector, they say, no. They just need it for money. And if you talk to the private sector, they will say something else. So we want to try and improve relationships of trust between actors. And in the long term, we hope we will have a more inclusive health system that provides both structured and meaningful opportunities for communities to have a voice in decision making. I'm going to pause now and ask Rudy if hand over to Christine. Christine, you're going to make a comment?
I don't have a PowerPoint.
No, you don't need a PowerPoint. But the thing you do need is this.
Can I speak from here?
You do need this. Because the camera needs to capture you.
Alright, so as outcome of this, we have to look at we fit into all this. If you want to participate in the private and the pluralistic system, we need to know what we are talking about as community members. So we need to know the relevant legislation. You need to know when you talk about the norms and standards for health, what is that? You need to know what the ideal clinic is. So that one of the things about the NHI is that your clinic or your health facility must conform to certain norms and standards. So one of the things is that you must have a functioning health committee, the clinic must be clean. So how are we going to lobby so that our health facilities are one of the facilities that are chosen where the National Health Insurance will be implemented? So for us, it's very important that we also learn from the partners that we have and what would be best practice for us to participate in the system. Most of all, right? We shouldn't be left behind in this whole 4-year process. So we, together with the academic, we're going to do most policy reviews and all that. We also need to know what those policies are. But important for us is ultimately being able to empower ourselves, so that we not be used by government or the private. So we have alternatives that are legislated. So how do we use that legislated structures to make our points in terms of keeping the system accountable? Then we also have structures in the community. And how do we also strengthen those structures to further keep the system accountable? So in terms of the private sector, I don't know how we're going to do it. I think we should go back to tires in front of the private I'm just saying, right? There's legal means and there are other means in which you can keep the abstract account. Thank you.
Thank you, Christine. We will now have the 3 countries present what is called as a vignette, which is like a short story of what is the context and what are the key questions that they will be addressing in this program. And we can have the 3 countries to present their vignette one after the other. Following that, we'll invite the speakers to come forward and share their reflections. So may I please invite Prasanna? Introduce yourself.
Yeah, good afternoon, everyone. Sorry, I don't know. South African. I'm Prasanna. I'm representing the India team. As Leslie showed, we are going to work on what I call activate or animate the health committees in 2 cities in India. So we wanted to just give a broad outline of where we are in India and then also put some reflections in for the panelists to also later on respond. So the first thing is, unlike South Africa, Indian Constitution does not guarantee the right to health. Even though this right has been read by some of the court judgments as right to life, which is a fundamental right, but even then you cannot go to the court and then demand some of the denials if you are denied healthcare. And India is also a system of cooperative federalism, and health is a state subject. So we further did devolution, and we had 73rd and 74th Amendment in which it was given to the local administration. So we had the national, the state, and the local administration. But the union government still holds the power to formulate laws, policies, and programs for health. So the so-called devolution is not a complete devolution. And on the other side, we have the public health system, which is highly centralized, despite constitutional legal mandates that the states have to do it or the local governments have to do it. And then there are centrally sponsored schemes that finance the states, much similar to what we saw yesterday in the field when we went to Manenberg and other places. So the union government exercises significant control on the health service delivery. Community participation structures have been mandated, mandated by the governments, by the health system, and not as an organic emergence from the communities. So there are also some representations or whatever we could call that of. But it is mostly relying on volunteerism from communities. We have been asking the same question to all our friends since yesterday as to, are you volunteering? Are you paid? Do they pay at least for your travel? So that sort of a thing, but none of those have been there. And particularly, women are expected to be part of these committees and part of these health committees and having to be doing the sort of monitoring. The committees ensured only tokenistic participation and did not achieve the goal of ensuring transparency and accountability. So some of these reasons is the over-centralization, lack of devolution of the health system towards communities. So there has been little or almost nil critical reflection from health systems on this community participation as it is currently envisaged, where women have to be doing it on a voluntary basis. So this raises some questions for us, whether invited spaces for participation, such as voluntary committees, which are not backed by adequate financial resources, the best way to institutionalize community participation. Given the lack of devolution or a lack of commitment to devolution of administrative powers and financial resources, how effective can committees be? So that's the second question. And the voluntary nature of work expected by health systems from women, is it justified given the time poverty, as in women having to do many more things and lack of time for women? How is it expected that that they contribute to the health system in of course unequal gender relations context? Given that health systems themselves are hierarchical and are quote unquote expert driven in nature, how can women demand accountability from health systems? So those are some of the questions that we wanted to put to the audience as well, and then also ask what is from the panelists. Yeah, thank you.
Hello. It's my first time.
Okay. You have to speak up a little louder.
Yeah, I need to speak louder. Okay. Hello, everybody. Nice to meet you. So I represent the Vinget from Brazil. So in Brazil, we have the public health system, which we call SUS, that is coordinated by the Ministry of Health, which stabilizes the main health policies and guidelines for the country. At the same time, states and municipalities can implement specific actions for their populations. Health services, however, are not provided only by public providers. The private initiative through profit and no-profit providers is hired, especially in large municipalities, to manage different types of health services. Public managers are the regulators of those contracts. Social participation is part of the system and should work as a mechanism that promotes policy demonstration and transparency. They are legally empowered to have a voice in the definition of municipal health plans and budget planning and approval. Historically, participatory health councils have opposed the contracting of service to providers. They claim that this partnership between the state and the private sector is in fact a transfer of activities and resources for the public to the private sector. That there is no guarantee that the private entity behaves in accordance to the public interests and that they submit professionals to precarious work conditions. On the other hand, municipal managers argue that performance contracts are helping to guarantee the delivery and quality of services offered to the population, as the public administration is very heavy and not being able to adapt to the needs of contexts that are experiencing rapid change. In their view, those contracts are bringing real gains to the population that use the public health care system. So we question, how can academy help in opening more constructive dialogue between social participation and public managers? And can social participation become an activity involved in contracts, definition, and evolution?
If you hold it lower down, but if you hold it lower down,
Tell us if it's too much noise.
And
So Therese and I are going to present a case study for, not a case study, but a case from South Africa. So as most of you know, South Africa's health system is characterized by being a two-tiered system. We have the public system, which about 85% of the population uses, and we have the private, which about 15% of the population uses. Quality of care, delivery systems, and incentives are very different across these two systems. The public sector is fraught with problems such as understaffing, under-resourcing, and management challenges. The private sector is known to over-service, to provide fragmented care, and allow fee-for-services to dominate clinical decision-making. Corruption is a deep-rooted problem across the health sector. Inequity in access to services has exacerbated, as you probably know, under COVID-19. The inequity is the driving force behind efforts to establish a universal health coverage under the National Health Insurance. So in other ways, ensuring that everybody gets the same kind or access to the same kind of care. And
okay, so now what we've done is we've made a short story. It goes like this. 4 adults are traveling by car along the highway on the outskirts of Cape Town. They are working class activists coming back from a civic meeting and have no medical insurance. It is late afternoon and there is a considerable glare on the road with the sun's rays slanting into the driver's eyes. A large truck appears behind them, driving recklessly, and they are forced off the road. Miraculously, the car is badly damaged, but does not tip over. All the people in the car survive the crash, but are mildly injured and traumatized. They are taken to the local public sector district hospital. There they join a long queue and they wait. It's unclear if they are triaged as low risk, but they end up waiting for more than 5 hours. When they are finally seen, the driver is sent for a plain X-ray and no abnormality is found. He's discharged with painkillers. All 4 people are very dissatisfied with the care they have received. Besides waiting to be seen, they believe the care they have received was substandard and that the driver should have been given a brain scan since he had hit his head on the driving wheel and is complaining of headache. Fellow activists they consult advise them to go to a nearby private hospital that has a unit set up to deal with road accident fund cases. So 3 of the affected people present themselves the next day at the private facility saying they were involved in a car accident and would like to get proper investigations. The clerk at the reception says that since they don't have medical insurance and because their case is not clear-cut, they will not be able to make use of the service at the hospital. They are told to go back to the public hospital for further care. Clearly, they are very unhappy because they do not want to face waiting in a long queue again to be turned away and to be given what they believe is inadequate care.
So based on this story, we are asking some questions around accountability and quality assurance. So in the public system, as you know, most facilities are supposed to have a hospital board. If there is a failure of care, such as in this case, then it should be picked up by a quality assurance system. And if that system doesn't deal with it adequately, then the hospital board should be brought in and take action. At least that's in theory. We know that that doesn't always happen. But in the private sector, there's no oversight board at all. So there's no structure that you can bring your grievances to. There's an audit system in the public sector, but it relies on an united leadership of the hospital and routine inspections from the Office of the Health Standards Compliance. The results of these audits, however, is often not shared with the public and not even with the board. The board play, in most cases, a limited role in ensuring that these audit reports leads to improvements. In the private sector, which we'll soon experience under the NHI, there are no obvious mechanisms for redress when a patient is not happy with the services or when there has been failure to deliver quality service. A private hospital ombuds exist, but only for the members of the Hotel Associations of South Africa. The remit of this ombud is mainly to do with billing issues. Since private hospitals do not employ private practitioners, there's a completely atomized system of accountability. If a health professional refuses to provide proper care to a patient, the complaint has to be made against the professional with the relevant professional counsel, so not to some of the other accountability structures.
Okay, so these are the questions that we ask, and they're written up on the PowerPoint behind me. Can they get redress under the present system? The public hospital provides a number which they can call to lodge a complaint, but there is no obvious way to lodge a complaint against the private hospital. That is as much as they know about methods to hold the services accountable. What would it take for an NHI in South Africa to provide seamless quality care for uninsured patients like those in this story? And how could the voices of these patients and others like them help to shape the health system to be more responsive to needs of those who cannot pay for health care?
Does that mean I have to come up?
Yes.
You know, when they put your picture up like that, you really don't have a choice, right?
Can I invite Melvin Woodley?
Sorry, go.
Director, Health Intelligence, Western Cape Government Health
Yes,
Department.
thanks, Shani.
Will reflect on this. Yeah.
Are you gonna? Good. Hi, everyone. My God, they keep on finding this picture. I don't send pictures and then they find this. This is, I think, on my LinkedIn. As long as they don't have any of my Facebook pictures. So good afternoon, everyone. I see some familiar faces. I'm now Woodley. I work for the Western Cape Department of Health. That's usually how I start things, right? But I want to test you guys. I say I work for the Western Cape Department of Health as a public servant. But who do I really work for? Us. You said us. Absolutely. If you're a government employee, if you're a public servant in the true sense of a public servant, you understand that you work for the people and that your purpose is based on what value you can provide to people. Also, I want to say it's lovely to see some familiar faces here. It's always a pleasure to be here with you. It's very interesting to reflect on the discussions that we've had so far. One of the first things that occurred to me was in all three countries, there are issues between the private sector and the public sector. Wherever there's a division, wherever there isn't one health system, there are issues. And I can reflect on the South African experience, and I'm actually going to tell you a little bit of a personal story. But I think it starts with the purpose. You see, to me, in the public sector, it's very clear what my purpose is. Now, we call ourselves the Western Cape Department of Health and Wellness. So there's two purposes. Number one, purpose one is to provide access to a quality, comprehensive healthcare service for everyone in the Western Cape. Everyone, right? Not citizens, not voters. Everyone. If you live in the Western Cape, we provide the service to you. The second thing, it's the and wellness part, is to work with other agencies so we improve all aspects of a person's life, their socioeconomic status, their safety, their food security, etc. So we've got those two purposes. Now, it doesn't feel right that just because you're in the private sector, you can allow yourself the luxury of saying, well, we are for profit only. And if one allows oneself to think in that way, and I want to say that this is not a criticism of the public sector. I mean the private sector. I value the private sector. I think they are wonderful people. But if you don't have clarity of purpose, then you essentially become a fragmented system that designs itself around what your purpose is. And if your purpose is I'm going to make as much money as possible, you become an entity that designs everything around money. Which means you're really good at doing hip operations because it generates a lot of money. You're really good at doing certain things that generate a lot of, you're really good at doing hernias, right? But you're not so good at dealing with psychiatric patients. It doesn't really generate all of that money. Now, I had a personal experience, just trying to work out time, about a year ago. And at the end of the day, I looked back at it. And I said, okay, if I'm unhappy, who do I speak to? And I think one of our speakers spoke about that. Who do I speak to? And the answer was, well, there isn't really a system. There's this number of there's a complex system of interacting pieces that ultimately do something, but it isn't a system. And that's something we have. Now, you might say, well, you work in the public sector and you're coming here and you're saying all these negative things about the private sector. And to that, I'd say, well, I think a fair and objective document is something called the Health Market Inquiry. And that was a piece of work done, extensive piece of work done. And I suspect that it aligns to many of the things I've said. So that's something to consider. But I think it speaks to why the value of moving towards a single health system, both in South Africa, in Brazil, and in India. Now, I spoke about the private sector, so I can't not speak about the public sector. And I have to be honest, we have huge challenges. We provide almost exclusive healthcare to 85% of the population, that's 7 million people in the Western Cape. Lines are long. The waiting times for surgeries are long. If you go to an emergency center, you may have, I'm talking a lot about waiting times, you may not have a good experience. Okay, one of the complaints is that staff are sometimes are not polite to patients. You may find a facility that's not clean or up to the standard that you expect, and the quality of care may not be that which you deserve. And I think these are all challenges that we need to address. The next thing I want to tell you is, you may wonder why I'm wearing a tie today. I'm actually coming from a department event where we are actually talking about community participation. In fact, the afternoon session was about community participation. And we actually spoke about our journey, and I thought I'd briefly touch on it. It's interesting that in 1994, in this province, it was primarily the three big hospitals, Krugerskit Tygerberg and Red Cross, a smattering of smaller hospitals, and a fairly functional primary healthcare system. And over this time, we have consciously invested in primary healthcare services, in keeping with Alma Ata, and in a desire to provide good healthcare to everyone in the Western Cape, to the point that we have, I think, about 273 primary healthcare facilities, over 60 satellites. We still have about 57 hospitals, but we've moved towards a focus on primary healthcare. In the last, I think, 5 years, there's been a piece of legislation published called it's called the Health Boards and Clinical Committees Act. I get the name wrong, but it was published in 2016. And in my experience, certainly the MEC and members of our department are keen to encourage community participation. Now, whether or not we're achieving that, I'm not saying we are. In fact, when I end this, I'm going to ask you the question, right? And I'm going to open myself up to it. Because if I'm true to what I said in the beginning, which is I work for you, if I'm going to be honest about that, then I need you to do my work assessment, right? So come, we'll do my work assessment. Right? So we talk a lot about community participation. I'm comfortable enough to say from what I've seen that the MEC and senior management are keen on it. They certainly have committed to it in terms of policy and in terms of saying we are committed to it. But I ask you to think about these two questions, since it's my job assessment. What is your assessment of community participation in the public, community participation? And I want you to give us a score. What do you think of community participation in the public sector out of 5? Don't give me the score right now, don't hurt my feelings. Give it to me, and then what is your assessment of community participation in the private sector? Right? Scoreboard out of 5. The second question I'm going to ask you is, what advice do you have for me in terms of how we improve community engagement? I assure you, we are serious about it. And if we are serious about it, then one of the things we have to do is actually ask the people we're working with, how can we do this better? So in addition to giving me the score, how do you think, what advice do you have for me in terms of how we in the Western Cape Department of Health and Wellness can improve community engagement? Thank you very much.
Do you want
That's up to you.
I'd like to invite Mr. Elroy Hollis, member of the Steering Committee for People's Health Movement, South Africa, to come forward.
Can everybody hear me? Olweni. Dumelan. Boa tarde. Boa tarde. Good people, goedemiddag. Namaste.
Namaste.
You know, what did I just do now? I identified with your language. And I wish government could do that better. But if I could respond immediately to the questions that were asked, building on what Melvin has said, listening to people really is the most important. And there are powerful examples by some organizations, and I work for one, It was called the Black Sash Trust. And the Black Sash Trust, along with civil society organizations, got rid of an immoral, unlawful, I can't say illegal for legal purposes, organization in this country called Cash Pay Master Services. Do you remember it?
Yes.
For those who are not South African, Cash Pay Master Services was a part of a large consortium called Net1. They had sister companies called, they're still around, Emerald Life, FinTech, I think is one, Umoya Manji, which was the tool to steal money from grant beneficiaries for things that they never asked for, airtime, electricity. Am I talking the truth?
Yes.
Do you know who embarrassed the CEO of Net1 and Cash Pay Master Services that he had to flee, and we exposed him for the lies and the corruption that he was guilty of? His name was Dr., not a real doctor, Serge Vellemont. We proved that he didn't have a PhD. We interviewed him. I was in the getaway car with grant grabs, going up to the floor. They didn't know who we were, and we got him on TV. On the Black Sash website, go and look it up. Grant grabs is an expose from people, including 92-year-old, he's late now, Tatabane from Nyanga, who was in the Constitutional Court of South Africa, witnessing the judgment of nefarious, immoral corporates. And I don't think that we sufficiently talk about the role of corporates in extracting wealth from our country. So the first thing I want to say is, how does this apply to health? In the public and private domain, can people get redress under the present system? The question is, who are you and what set of tools you have? The first thing I would recommend is community. We must understand how budgets work. Economic literacy is absolutely critical. For a year, I had the privilege of working for the Alternative Information and Development Center. But before that, I was trained by Fair Share, which is part of UWC School of Government, in the mid-90s to help people understand how budgets work. So, Melvin, I want to ask you the question. In real terms, has there been a cut to the Western Cape Department of Health in terms of the division of revenue by the National Treasury? Do you know? Not a trick question.
No. So it's not a trick question, but the budget letter hasn't been received yet.
Okay.
So if I gave you a technical answer, it might not be accurate.
Okay. Let me tell you what the Budget Justice Coalition has said. I serve as a member on the Budget Justice Coalition. They are a coalition of 22 NGOs and CBOs, including Section 27, the Treatment Action Campaign, 350.org, so national, provincial, and local organizations, the Alternative Information and Development Center, and many others. And you know what they calculated? They calculated that the cuts to health, in real terms, the Treasury failed because health, the average spending per public health care user fails from 5,028 Rand per person in 22-23 to 4,605 in 2023-24 in real terms, by 6.5%. Now, how do we know this? It's simple. It's right there. These numbers were calculated, corroborated by a senior economist, a former colleague, Dr. Dick Forslund, by people who have experience in that. And colleagues, we need to understand that. We need to understand things like, as the tax to GDP ratio, all the money that we collected, that slice that comes in the form of tax, what percentage went to health? Health is a provincial competency by and large, except national policy like NHI. And then we need to critique, unpack, understand, and make contributions there. In the interest of time, I said we need to listen, document, report, and put pressure on government to do that. The CMAP report, Community Monitoring and Advocacy Report, monitored SASA, as I said before, pay points, service points, but they also did basic services and healthcare on a very much smaller scale. As a result of that work, and some people know about that work, we were appointed, including myself and the former director, Lynette Mart, to a ministerial task team to stop these deductions by none other than former Minister Patabile Dlamini. Now you will say, why? She was found guilty of perjury, right? But at the time, she was the person in charge. And after lots of consultation, we thought, this is a way to stop the process. The lesson there is understand the times in order to know what to do. Question 2, how can we make the NHI seamless? Well, it's going to take a long time. I don't think it's going to be attainable in the next few years. Wonderful initiatives, great policy. And for a while, when I was with the Black Sash, I was appointed to the ward-based primary healthcare outreach teams, which is a requirement for people to engage on the closest level. And that broke my heart. It broke my heart when I was part of the Department of Health. In fact, I left because of that. And the former head of the unit I reported, Dr. Jogan Pillay, asked me if I wanted to stay on. He has left the public service. And I would think, in part, that it's because of the failure of the state overall to do that. When I visited all 9 provinces, along with this team, all across the country, our sisters and brothers, our mamas, who without pay went to measure the blood pressure, the glucose levels, contributed to important statistics like infant mortality rate and maternal mortality rate. You know what? They walked in the sun. They had no PPEs, most of them. They wanted to speak to me alone. Elroy, I don't want to speak loudly, but we're struggling here. How can we subject our mothers and sisters to that level of service that they want to give with their heart, that they know will determine whether babies will live or die, with such disdain? That's why we need to understand how budgets work. My final point is, let me put it this way. I want to tell you very quickly a personal story that happened to me. And the personal story is this. I hit my head at UIF. I hit my head at UIF. So I'm between jobs and I paid UIF. So I went to town and I stood in the queue. I came there 5 times, from 7:15 to as early as 6:45. 2 days ago, I was finally helped because the queues were between 40 to 60 people outside the building. And you know what? I finally got help. Well, kind of. I've got to go back there in 35 days to see if my UIF is due to me or not. They've got a new system now, point system. It's not on the website. So what I'm saying is that the entities, the 128 entities, public entities of our country are failing. I hit my head in the toilet. I tried to pull the door open. Bah! It hit me in the face, broke my spectrum off. Luckily, the lenses weren't damaged. The only contribution of the private sector for me was this. I had to go and replace the lenses at Neo Vision in KC. So that's going to cost you 500 rand. Yes. But we can give it to you for 300 rand, which I got. So a 40% discount on something. That's how the private sector, in my mind, says, oh, maybe we can do it here. They reduce it to economics only. And I think that must stop. The private sector must be held accountable to the same measure as the public sector is. Thank you very much.
Thank you for sharing those experiences. It is very important questions on budgets. I'd like to invite Moses Mulumba. Director of Afna Yahaki from Uganda to share your reflections on it.
So it's afya na haki. It's a Swahili word meaning health and justice. Now, very happy to be here with you, comrades. It's a tough one, speaking for 10 minutes about a very important subject. I come from Uganda, and I'm extremely excited by the topic of conversation today, given its relevance in the context where I come from. I think that I'll majorly comment about the conceptualization, the project, and what it's going to address. I can't finish all the case studies that have been presented. I think that the project starts on a good footing. In many cases, when we talk about the private sector, talk about private sector in a dismissive way. And we miss the opportunity to shape the workings of the private sector and how the private sector can do better. I agree with the previous speakers that the objectives, the public and the private sector are very different. I certainly want to remind ourselves that what we want to deal with in the context of community participation is very historical. When I had colleagues from India speaking, I kept thinking about the history of India and Uganda and the health systems. The colonial legacies and the current conversation on neoliberalism cannot actually be left in the conversation. I think that this is very, very important. One thing in the context of my country that we are leaving out is the definition of the private sector. Colonialists left facilities they call mission facilities. We don't know where these fall. Are they private? Are they public? They have very clear missions to serve the public, but the way they are working, church-based, mosque-based, they are like private, purely private. The charges they levy and the assistance that they give. So the pluralism is much more complex than we think about it. Still, in the colonial legacy, when you think about participation, many of the spaces for community participation where communities used to come and think, the practices and the thoughts that they used to have in the Ugandan context, those were equated to witchcraft. So I don't know if you know what witchcraft is. Sorcery, witchcraft. So if you came together and had any talkings about health systems, you would be classified under the Witchcraft Act, and it became an offense. So health systems were left out of the communities, and they became more formalized in these mission hospitals that were created. And then later on, we saw that the governments began to pick up and turn some of the mission facilities into public, and others remained as mission as we speak today. So despite the central role that community participation would have played in the evolution of health systems and the role of communities, we kind of lost it. We lost the language of communities. We lost the inputs of communities. Now, at a global level, by way of response, we saw interesting happenings in the 70s. We talked about the Almaty Declaration and the power that it came with. I think around 86, we had the Ottawa Charter. We saw the power of the people coming back as part of primary health care, not just as a right for people to participate, but as a duty for people to also participate. And I think Professor Leslie has talked about that as something that is important. But somewhere along the way, again, that power that we saw at a global level that was institutionalized in public health facilities in many of the countries got lost with the structured adjustment projects and programs that came up. Governments were convinced that they can't do business. And they were convinced that essential services like health were actually businesses. So they pulled out. So as you talk about private, you're talking about a situation where those that are giving public have disempowered themselves so much that they have left those that are giving private to actually be able to do things. In Uganda, in the last health facility survey that was done about 4 years ago, the private health facilities about 50% at the moment. And they are increasing, I think over the last 5 years that we assessed, they had increased by almost 200%. So it actually means that they are moving much faster than the public. So as the government is establishing more public facilities, the private are actually moving much faster. And I've read about India and other countries. Situation is almost similar. So it is classically true that public is still important, but private is growing much, much more stronger. So the question is, from the history and from what we see, can the private replace the public? I think that would be very wrong for us to think about it. The issue is how do we draw a middle ground? And there are some arguments that I've been thinking about. Probably we need to argue that the private sector is taking on a delegated function from the public. So while the laws that we all made or we inherited in our countries have been laws that have been targeting the public, probably we need to find a way in which those laws and policies begin to apply to those that are providing services through the private facilities. And in a way, the principles that we are talking about that enhance community participation through the public lens would certainly be important. The big question is, do the government still have control over the private facilities in many cases? What have we seen in COVID-19? I think because many of the public facilities in the context of where I come from had already collapsed, we saw that the vampire in the private sector had actually arose. So people had no option. And for the first time, the politicians had no option of flying out, come to South Africa or go to India for better facilities. They had to face their own country facilities. And the best functioning facilities throughout COVID-19 were the private. Even the public oxygen that was supplied through the public chain would end up in the private. But there are serious questions around how do we ensure that governance and community participation continues to play a central role. The private sector understands one thing: the health provision must make business sense. Are there arguments where community participation can make business sense at all? I think these are the things that the project needs to find out and needs to think about. The last point for me is that over the years, we have thought about community participation from a democracy and political perspective, and later on from a human rights perspective. I think what we are learning from the history of public health and public health approaches, we need to begin rethinking about community participation, not just as a democratic value or human rights value, but it's part of the public health interventions. And there are serious lessons to learn from as we think about the private sector. Harm reduction as mechanisms where we have seen the communities actually participate in drug users, harm reduction in access to safe and legal abortion. It's a public health intervention, but there has been much more community participation in that. And yet, those public health interventions that are important do not have the legal value or the policy value that we actually see in the democracy and human rights value that enhance community participation. So a lot of food for thought. Thank you very much.
Thank you, Moses, for those very inspiring words. May I invite Assistant Professor, School of Public Health, University of Western Cape, to that.
Good evening, everyone. In the city I lived in for many years, we would say San Onani, Salbona. I just want to say a few things about participation based on my experience and my teaching. I'm a teacher by profession. And listening to the presentation by Professor London and the vignettes and my other colleagues, some of the things that came to my mind is what aspects, and there's so many questions that came to my mind. One of it is what aspects of the healthcare system are we looking at? So what aspects do we want people to participate in? And then what levels of participation are we talking about? Because we learn from theory, from the authors that have worked extensively on participation, that there are levels to participation. So for me, the question is, what aspects of healthcare are we looking at? I know that when Professor London was talking about designing, co-designing a model. What aspects are we looking at? And what levels of participation are we looking at? Because participation can be at a very small level, like a level 1, which some authors have termed non-participation, in which maybe you're just informing people who want to do this, and then they give a stamp of approval, and then we say, oh yeah, people participated. Or are we going to the middle level where we do extensive consultation, or are we going for the, the highest level, which is where the people have a say, and where whatever they say counts? Okay, so that's one thing to think about. The other thing that came to my mind is the issue of the costs of participation. What does it cost to participate? Does it cost nothing? I had one of the presentations where, was it somebody from India who said they went out yesterday, and you were talking about how do people transport themselves to these meetings, the health committee meetings? How do they pay or pay for the value of the time that they invest? Which leads me to the next point, which is participation an end in itself or a means to an end? Do we, when we participate as health committees, as board members, do we then say, oh yes, we've done it? Or is there more to it than that? Is it, and what's the benefit of it? So the benefit is it the healthcare delivery that we experience for our communities, or can there be much more that comes from participation? And in participating, are there skills that are required to participate? Do we need to capacitate people to participate? And one of my colleagues was talking about learning how to work on budgets, right? That's a skill. That's a skill. It's a skill set. Are there different skill sets that are required to participate at the level where the participation is happening? Okay? So these are just food for thought, my colleague said, just to think around the things that might come up in the project, but also the issue around leadership. So when we talk about participation,
in communities. When we come together and we're more than one, we want to elect a leader, right? So the issue of leadership, what kind of capacity does the leader need in order to mobilize people who are participating? And then comes the question of followership. What do the followers need to be able to fully participate at the level that we want them to participate? And then thinking about the areas that people are participating, the levels of participation. Are we interested, for instance, in the drug prices? Should people have a say in where we buy our drugs from? Or who makes our drugs, or the supply of the drugs? Or is it just about what happens in a local healthcare system? I could go on and on with different questions, but I'll close with this. When people have participated, what do they take home from it? I'm not talking about cash. I'm talking about tangible things. Do we leave them the way they were before they started participating? I'm talking about those who devote their time to participate. Do we leave them the same way? Or do they take a lot of value from it? Thank you.
Community is power. We have about 5 minutes to take some question and answers or any reflections that the audience may have. So the floor is yours. Unfortunately, the mic cannot travel too far from this place, so I'm sure that you're all each loud enough to ask from where you are, but if you need, then you can always come forward. Do you want to?
No, I'm loud of the short voice. Thank you for your input. There's a lot to ask. Where's to Moody? Yeah. From the Western Cape down. And you know, we don't want to repeat the frustration that we have as communities. According to your questions, we don't want to even answer your questions. You know where we are in Western Cape about health issues. But my question will be direct. Why you have to be invited to such events in terms of asking those questions? We are talking about community participation here. How is your relationship with community? As per your questions that we're asking, that we must rate 1 to 5. But just doing introspection, where are you as Western Cape government in terms of whatever health issues, community participation, right to health for our community? You know, because this is a frustration repeating everything that is happening in our township, that you sitting in your office don't even experience what is happening here. Can I ask all the questions?
Thank you.
Thank you very much, Alex. Just to support what she just said, you know what? While you were, I'm sorry that we are going to point at you now. While you were standing there in front, from my side, I thought that maybe you are from India. Why? It's the first time I met you. And we, as the community activists, we are suffering down. You are not there to assist us. We must do the work. Whenever there is trouble in our clinics, where is the health committee? And yet you are in our office. You are not there where the community is supposed to do what the community do. You're supposed to assist them there. But you are nowhere to be found. Please, 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 please. Pull up your socks and come down to the people where the people are. Thank you.
Good evening, glad being here. Mr. Albright, lucky for you, you had the 300 Rand on you for your speaks. I know community members that run every day to the hospital. Is the appointment for your speaks? Come tomorrow. They go again tomorrow. Come tomorrow. There's a lady that is fighting now for 5 years to get a proper appointment. I met her the other day. People come to us like, she says, they come to us, Sabrina, I need to get a disability. I've got high fever and scar, I've got low blood pressure, I've got this and that and the other. But what does the doctor say? They don't want to put me on disability. What can I do? I can go to the doctor and say, Doc, check out this woman here, man. Put her on a disability. So people have challenges. And what do we? We are just community members trying to assist, trying our utmost best. But out there, we seriously have big challenges. And these two issues just came yesterday and this morning. I mean, one after the other. What about the day before that and all the challenges that we have? Now we're having the measles vaccination. What's happening? I found the school. I said, school, what's happening? As a nurse, been there already. I go to the creches has a nurse. I put on my status like every single day. Guys, you're putting your child in danger. Go out there. And there's like no response. And I said to my family, I actually mentioned their names on the family chat. I say, Melissa, did you speak to your creche? Was the nurse there? Did you take your child to the clinic? Come on, guys, you're not even responding. You know, we're getting excited, we're waiting data, and we're unemployed. That's not an issue, that is fine. But we got challenges. Nobody's responding. It's like, how come I'm upset? Other communities are upset. Measles is serious, our children is in danger, but it's like nobody cares. So we seriously got huge challenges on this. Thank you.
Question Dr. Mood, in your question is responding to
question, what advice do we give to Department of Health on how to improve community participation? Let's go and review the end past, like 2016. Do away with the appointment system of health committees and hospital boards, because honestly, it's not really assisting us. Somehow political, because committees are getting to decide who share points. It does not create that participation from the community. Also, when doing that, revisit the powers that you give to clean committees and board members. These people are community representatives monitoring the public health service. Now, when you give the body powers and then you limit clean committees, but these people are doing the same thing. So my advice is that let's go and revisit the act, check if possible, maybe we can change so that it speaks to what we want to achieve as a community. Because alone you will never succeed. Minister says, let's close the tap while we're mopping. Who's mopping? Who's closing the tap? Again, moving straight to Prof. What I noted with that question. I forgot the name. But the questions you posed on what's the cost of the participation. We are health committees not funded. We are able to do what we do through collaboration. And if it wasn't for that, honestly speaking, we wouldn't be sitting where we are, or the community's voice is heard in whichever corner. So if it wasn't for a collaboration efforts, we would be out. The system is not really speaking to community participation. You speak community participation, you have other sources. You don't speak community participation, the next thing you expect the same people who are from the community to use their 10 rands and 15 rands, which they don't even have. What is it that we go home with after a participation a lot? It depends on an individual that is active as to what is it that you pick up along the journey in participation. One, we acquire skills. Out of the participation here to treat communities, other developing interest, and you manage to spot a career that we didn't even think you would fall. I'm referring to Abu Visela Gula from TXT, Abu Abeli, who are now who are also studying social workers and stuff. So amongst the participation, people find growth and be able to identify spots where they feel. Let's initiate projects. Let me shift and follow a career. Make one shows interest in becoming a doctor. So in participation here to somehow there is growth, and it contributes as well to family leadership. When you are a leader, you give guidance irrespective of age, because you gaining a skill outside, and from where you are, you go and implement, not just in a space where you're operating, but also within the family. And again, designing a model that speaks to community development and community participation. There are levels, yes, there are levels. It needs us to come up with that model so that we influence government, to influence all sectors, to say, look, this is the model, it's working, let's test it. Thanks.
I think Christine, my name is Marian from the Manila community. I think Christine has highlighted the last point, don't leave us behind. And I think that's a crucial point that she has raised. I think many times how communities are left behind, because I think governments and people make decisions on behalf of people, and we're not part of that decision making. I think that is a crucial thing that should happen. And other question I think to myself, does academia understand public participation or community participation? Do they really understand what it is? And how do we as a community understand? And I think the Prof of UWC has highlighted, do we, and the tangible things, I think many times people come and use us as communities, but the tangible things that is behind isn't happening. And those tangible things is things that should make us proud as community participants. And I think the other thing with the NEC is that, and this is my gripe, is that we are called to these meetings whenever the NEC decides we need to come, and then she doesn't give all us opportunities. And when we speak, raise our voices, we are shut down. And I think those are some of the things that we need to look at in the Department of Health. Yeah, so is it a tick box exercise, or do you really want us to come and participate? Thank you, very important.
Oh, okay.
That's the last question.
I'm coming to you, Mr. Moses. I think I want to reflect on this point. When every time the South African government allocate a budget for the health department, they are only focusing on building hospitals. But I think my advice from the health guy who asked, they must first look at the back where they must clear to the existing hospitals, not going to build another hospital where they left the task behind them.
The last one.
I know this is supposed to be a different space, but we had interruptions.
Okay, all right, thank you. So it's a enough staff member. So my questions are directed to the PIs and I suppose also to the IC. And so to the PIs, the one question that I had was around the framing of marginalized communities. What do you mean by that? I mean, one side is in Gqeberha, the other one is in the Western Cape. So who are you referring to when you're talking about marginalized communities? So that's the first question. And the second question is, I mean, I was trying to understand if the community representatives are understanding who this partnership is with. So, I mean, this is now my own interest. Is it UCT and the other partners from Brazil and India, or is it the Western Cape and UCT and the other partners? And then the third question is, because this is a 4-year project, what is going to be the role of students? The role of students. We teach, the future healthcare workers. So what is going to be their role in this project? And then the very last one, I call it this, they come through tried, to rate the study aid and all of that. I'm still not picking up what is the benefit to the communities. I understand about community participation and the intention of the project, but what is the benefit to the communities? What is the long-term plan? I know that there are issues around the NHI, what is the benefit to do, but within this project, what is the benefit to the community? Thank you.
I'd like to ask the speakers if you want to briefly answer or say something.
Yeah, perfect. So I don't have an answer. My uncle, I'll tell you a story about my uncle quickly. He said, you have 2 ears and 1 mouth, so you should speak less than, we listen more than you speak. I think what we've been told, we've been given a brief from the Department of Health to listen. And you didn't give me a score, but I guessed your score. And it's frustration. What you're telling me is you're frustrated with the service that you're getting. What you're telling me, as I said to my employer, is to pull up my socks, which is do better. And that's what I'm going to take that with me to my for my own learning. And I'm going to go, it just so happens to be in that meeting, and I'm going to report back to my colleagues that this is what the community is saying. I think those points about the legislation and about how committee members are selected, I can't say they now, very powerful points. And then, as you said, man, we have to take the community along. It can't be lip service. It can't just be, yeah, we're going to say it because it sounds nice. And then when you say hard things to me, I defend myself and say it's not that bad. And I fight and I argue. I'm not arguing. I accept your points. Thank you for giving me that feedback so that I can try and be better for the people that matter, which is yourselves.
So my late mother, God rest her soul, whenever she got angry at me, she used to say, "You were a difficult person. Your father ate peanuts 2 days apart where PMH used to be. The Lord will forgive me. I brought you into this world, and I take you out." That was my late mother. My sister and brother were born at home. In Afrikaans is the word vroedvrou, the midwife, the doula. You know, that doesn't even seem to be under discussion. Maybe it's because we're the Western Cape and we've got 3 tertiary institutions, universities, and quaternary services, Red Cross. Maybe we're just so privileged compared to other places. But I think there's a role for women who are trusted in the community. The experience and knowledge can be supported so as to ensure the safety and the inclusion of people in medical services with professional guidance, never at the risk of the patient. So there's a limitation to that. I think the second point I want to make is in response to the lady who said, "I'm lucky I had 300 rand." You're absolutely right. I recognize my privilege. I have a family, a daughter, and my wife has income. We have a car. But I did a quick mental survey in my head when I was standing, I don't know which day, in that queue. And after 40 to 60 people, I asked them, "So where are you from? Where are you from? Where are you from?" Some said Hout Bay, some said Luxembourg, some said Kalditcha, because they want to get to a center that in their minds is productive compared to Guru and Bauer, which from a UIF perspective, they had very bad reports about and experiences from. So the point I'm trying to make, the state is actually not even like on pause. I think the state, because of its lack of honesty in terms of saying we are struggling, tell us what would work better for you, is in fact robbing people of money. If you calculate those 40 to 60 people and take an average of 30 to 50 rand, multiply it, you get thousands of rands every day being extracted from people who are already vulnerable. A man said to me, "Yes, turn away again. Where am I going to get the money tomorrow to stand in this queue in the hope of being assisted?" That to me is unacceptable. And there needs to be ways in which lessons from other civil society initiatives will empower, enable, and inspire us to hold government accountable in a manner that is constructive, that has a win-win situation. But it's going to be difficult and it's going to be fraught.
So I'm going to. I'll respond to and see questions. I think I only met the 3 of the 4. You asked about benefits to the community. So it's quite clear we can't do this work without providing benefits to the community. And the co-design is about the benefit. The co-design is empowering the communities to shape what kind of policy it develops. And we have a record of working with communities on this, and the 2 communities working with the Cape Town are Kalditcha and sub-district. So we would continue that kind of work around empowering communities to make a difference and to influence policy. We've seen it in different ways that health committees have tabled submissions around the NHI, tabled submissions around alcohol policy, have trained themselves, have responded to code of to protect their own communities. There's also material benefits that some people have been formally trained, and we would continue with that. Your question about who is marginalized, so I think that's a really important question. And I suppose we're working with communities who struggle with access to healthcare, and that's our definition. And partly we chose communities with whom we have worked with before. In America, we've had previous projects working with Nelson Mandela Bay Metro, and that is how we will go forward. I guess you asked questions about communities that have lots of access to healthcare and how they would engage with the system. And that's an important thing for us to reflect on perhaps as we go forward. Question of students, clearly students will be built in both through formal training, but also other kinds of placements. We have students who are interested in practical working with communities. We've had students before work with communities who have quite a good way of making sure that what they do is actually done with community partners and benefits community partners. So that it's not just a student coming in and making off with their masters, and we will continue that tradition. I don't know if there was a fourth question, but I can't remember.
So the fourth question around the community participants understanding of who the partners are.
Well, I think we had a whole day yesterday, and they interacted very solidly and have spoken with their colleagues. And it is a partnership of each site with their own community as part of a bigger network. So in India, it's also the case that we'll be working with local communities. We work with local communities, same in Brazil. So it is on that basis. Yeah. I think we need to wrap up because we've run a bit out of time.
Professor London, no, I can speak with other matters. Director, there was a mandate out that the youth should use the facility. The government said that the youth should use the facility. You know about that?
In terms of the youth training services.
That the youth must come in the afternoon to make the facilities. You know that? Okay, it was, I'm from the Dr. Monday Hospital. And then I went to 7 high schools in my area, right? 7 high schools. And the challenge there is, they gave me, Mr. Elroy, spectacles. These guys come with specs that has been patched. And Garlandale, I said that they got excellent learners, excellent, and they cannot afford spectacles. Guys also being at the back there, you know how the youngsters is, they don't want to admit that they cannot see what's happening on the board. So is there no way that we can have another project? I think we should have that project. We go to the schools and give spectacles to the learners. Our learners are failing because they cannot see the board and they don't want to admit that they cannot afford spectacles. That was most of the high schools that I went to admitted that spectacles is a thing.
Sabina, I'm going to ask them to go and call you after the meeting and explain what is possible and what is not possible rather than
days away.
Please be as brief as you can.
But I will not be quiet with the director of health, more special intelligence in the Western Cape. It's the first time that we're meeting him, and of which, if there was not this much of this ComPlus research project, we're not going to see. But what I want to make at the first, as we talk about ComPlus station in our areas, it's look like that it's a Greek language to us because the Western Cape nothing that is Greek station. Even the acts of excluding communities in the health facilities, we stood up and as organization different in the Western Cape, saying this is how. Now as we speak now in our health facilities are run only by the government. So that is not acceptable. Also, when we talk about participation, this institution, I arrived when he was finishing his presentation from the Western Cape. Then now we are working with the university like that. We choose to work with the university, but we work with the university as communities because they've got an ear to listen to us. But that is the lunch box that I'm giving you. You take it back to the UWC. What is the UWC doing in terms of group engagement and group participation in order to bring higher institutions closer to the people? I'm lucky that the lady in front of me, she said she's a staff.
But we want them to give a proud back to the community when they're teaching these kids, and they must come back to introduce these kids out of it. So this participation, if that there is a new term, pluralistic, that we can get implemented. Now this research is going to research worldwide practice in partnership with India and Brazil. Here it was supposed to champion in the development of champion public participation. That is why we are having this challenge. But instead of putting us together, we are creating a gap in between. So director of intelligence, I think you need to come there. I'm challenging you to come to Aisha and having a full day to get engaged.
I think both those comments are comments or challenges to the panelists, some of the panelists. I don't think we need to respond to them, and if you want to catch them afterwards. I want to thank everybody for participating. Can I just ask the other ComPlus colleagues, you know, Shruti, Carl, Vera, Sureka, Vinod, Prasanna, Kanda, Inaya. So if you want to call anybody, and if you want to call any of them to ask them any questions you have, please do so while we get some food outside. I'm going to close because two of the panelists resorted to stories about their parents. So I'm going to talk about my parents, something my mother told me. My mother told me if you have a good thing, hold it with both hands. So I'm going to ask you to clap and take the floor.
Sorry, one last thing. I think it answers the questions that most of you raised. Where I come from, it is not very common in universities to have a room like this, 2/3 from the community. So this is an intent to do something together with communities. And community participation is not a tick box. It is a long-term engagement, which can only be taught by working together and a frequency cycle. So thank you for that.